Well, welcome to Grand Rounds. I appreciate the ginormous crowd here, but I also do appreciate all the people who are coming in online, so that is a large crowd. Today we have Giovanni Stracco. Dr. Stracco received his DPT at Arcadia University. He was fortunate enough or unfortunate enough to graduate with me. He's board certified in orthopedic physical therapy and has treated orthopedic injuries with a focus on spine pathology and manual therapy for over a decade. Dr. Stracco is the spine program manager for St. Luke's Physical Therapy, where he works to educate staff and students on treatment of the spine and associated injuries. He also helped to create and manage the multidisciplinary comprehensive spine program at St. Luke's, which is aimed at improving the quality and access to care while decreasing the overall cost of healthcare. So without further ado, I'll turn it over to Dr. Stracco, and he'll talk about clinical decision-making for acute spine pain.
Okay, thanks. So Steve already went over the title. There it is. I'm definitely going to speak less in this lecture about how to treat patients with acute spine issues and more about what to do with them. Okay. Disclaimer, this is Steve's slide, right? Steve puts these in all of his lectures, but the planning committee members have no financial relationship to disclose. Presenter has no financial relationship to disclose. Okay. So, through these housekeeping things. Our objectives today, we have 4 objectives. We're going to describe at least 3 components of the multidisciplinary comprehensive spine program. We're going to describe at least 3 outcome metrics that demonstrate patient success. Given a case example of a patient with acute lower back pain, we're going to defend treatment progression decisions. And given case examples of patients with acute back pain, we're going to defend a referral for further diagnostic imaging. So, comprehensive spine program. You guys are familiar with everything? Okay. So we'll kind of go into a little bit of the program, although everyone sort of is familiar with it. So there's 4 sort of major reasons that the program was developed. The first one is the high volume of back pain patients that we see in our network. 50,000 of those, 50,000 patients with acute lower back pain per year, which is a significant number. We're looking at cost containment. So lower back pain is the 4th highest cost for our network. Lower back pain is the #1 cause of disability in the world. So we have a strong need for standardization of treatment. And then the 4th reason is opioid dependency. Back pain is the leading diagnosis for prescription of opioids. Okay. So this is a simple overview of the program. This slide is insane. Yeah, it's insanely complicated, but it's to illustrate how insanely complicated the program actually is. So I kind of put together a little blurb here that really is the whole program in one. I'll read it to you here. The utilization of the comprehensive spine triage line and primary care physical therapists as first contact providers, we're able to have patients with spine dysfunction be seen by quality clinicians quickly while decreasing the cost. Once patients are in the program, they have more immediate access to all specialties as they are expertly guided through their care by their primary care physical therapist, or the PCPT. The PCPT has the ability to refer other providers, refer for imaging, or refer to telemed for pharmacological intervention. That's pretty much it. And all of this stuff that you see on the screen basically is how we do that. The comprehensive spine program is not just physical therapy, though. It includes primary care medicine, urgent care, pain management, ortho, spine surge, neurosurge, physiatry, behavioral health, nurse triage, central scheduling. All of these people take part in it. Basically, it's extremely complicated. So, but the idea is that we get patients in faster, we get them treated, it costs less. The ultimate outcomes that we're looking at to determine success of the program, the first one is cost of care. We won't know these numbers for another year or so. But right now the numbers are looking pretty good. But it takes at least a full year of running the program before we know them. And we're at the year mark, September, right? Yeah. The second one is improved access to care, how fast we can get these patients in the door and the services of care that they need. This actually is well illustrated in the first case that I'm going to go over today. Improved satisfaction. So people are happy when we treat them quickly. Everyone has gone through the bureaucracy of healthcare, and people notice when we expedite that process for them, right? So access to care. So right now, 1,542 patients have entered the program since its inception. That's a pretty significant number. 83% of those patients have received movement consultations by our physical therapist. That number is about 1,279 patients, 83%. So that's a lot of patients that this has generated for physical therapy. Access to additional care. So our primary care physical therapists refer on for further services, whether it be imaging or referral to another clinician, about 15% of the time. All right, so patients entering the system through the comprehensive spine program on average have about 4.55 visits, which is well below the national average of 11.08 visits. So we seem to be getting these patients better much faster than the average clinician is. Do you guys have any idea why that might be? Anybody? I think it's because we have put the best qualified and the best trained therapists in these positions to see these patients first. So whether you're a patient of the program or you're a referring provider, you can be assured that your patients are going to get the best care by seeing the best therapists. Patients receiving care through the comprehensive spine program report 98.93% satisfaction, which is in the top quartile of the nation. So the program seems to be working. We've been seeing patients quickly, saving healthcare dollars, underutilizing services, and we're still achieving a high satisfaction rating, which is great. Okay, so that's kind of overview of the program. Most of the people that are listening to this right now know that or know those kinds of things about the program. So I'm going to go into 3 different cases that sort of illustrate some of what we've been doing with our care. So the first case is Mary. She was actually my patient, so it's not why I chose it, but I actually chose this because it really illustrates that quickness that we're moving through care through the program. So everyone here is familiar with photo. She scored a 21 at her initial visit. She had a startback score of 7 with 4 in psych, so it put her in the high risk category. Okay. On her first visit, she told me that she had a high level of fear. All right. It was almost one of the first things out of her mouth. She has a history of alcoholism, and she was very fearful of taking any medications that could be addicting. In the same breath, she had also told me that she was taking an opioid that her primary care physician had given her. So that wasn't great. A little history, though, what's going on with her. So she had an unknown etiology. The patient notes worsening pain over the past several weeks. She's having pain in her left foot with symptoms that are when symptoms are bad, and sometimes has giving way of that leg, her left leg also. Her pain had led her to see her primary care physician twice and the urgent care once. So both suggested that she called the comprehensive spine triage line. That was within a week. So she had 3 appointments within a week before she called the line to get in, and she saw me that week also. The patient normally enjoys yoga, bike riding, neither of which you can do at this time either. So the 3 things that you kind of want to take away from just the history: the patient has symptoms progressing into her foot at times. She's had 3 visits to the PCP in the urgent care, and she rates her pain at 10 out of 10. So physical exam findings: there were no red flags at the time of the evaluation. No neurological symptoms at the time of the eval either. Though she reported symptoms of radiculopathy, I found nothing. Normal posturing, limited range of motion in all planes just due to her pain. She had a comparable sign with UPAs at L3 through 5 on the left, which increased lower back pain and centralized her neuropathic symptoms. So there were some other findings, but nothing that really suggests a referral beyond physical therapy. So that's kind of the takeaway message from her physical exam. My assessment was that this patient had symptoms of lower back pain and left-sided radiculopathy with concurrent L4 through S1 hypomobility issues. The patient's symptoms were consistent with acute lumbar radiculopathy, and the patient had relief with extension-based exercises and mobilization. I also said that I would consider a referral to pain and spine if the patient is not showing signs of improvement over the next 2 weeks. I also would consider that referral just because of her being prescribed an opioid by someone that isn't necessarily tracking it too. The possible referral would also be based on the severity of the pain giving way and the possible progressive nature of the symptoms. So treatment for this patient was not, it wasn't really possible, actually. So the patient didn't tolerate any movement. She felt only slight relief with lying flat on her back with her legs crossed. So that was sort of the only way we could reduce her symptom at all. A referral was made to Dr. Love in Quakertown for an MRI due to the progressive nature of her symptoms and consultation for an ESI. So I made that referral the second visit because she was stating that her symptoms in her leg were worsening. So the outcome for this, the patient had 5 total treatments of physical therapy, and she was referred to pain management for the severity of her symptoms after visit 2. The imaging impressions were that she had severe facet degenerative changes at L4 through 5, causing an anterior listhesis, resulting in right greater than left foraminal narrowing with mild central stenosis. The MRI was indicated and the ACR guidelines were followed. So the timeline, sort of the takeaway message from this patient is that she was better suited for treatment for pain management. Her referral was made quickly, her appointments were made quickly, and what may have taken in the past greater than 6 weeks to accomplish, we only took about 2 weeks. The process was facilitated by Dr. Love and myself, and we have an open line of communications. We spoke before and after her treatment or her visits, and I think one of the takeaways from this is that you need to have that open line of communication between you and whoever you're making your referrals to. Sort of the most impressive part about this case, I think, was within 2 weeks, within a 2-week window, the patient was triaged by nursing, seen in PT for 4 visits, had pain and spine consultation, an MRI, and she had a steroid injection. 2 weeks. So that's pretty significant, I'd say. Okay? Any questions about Mary or that case? We can talk at the end too if you guys have any questions. All right, so we're moving on to Jimmy here. So Jim came in with a photo score of 53. Startback tool gave him a 6 with a psych score of 4, which put him also into the high-risk category. A little history on Jim. He had a 5-year history of lower back pain with radicular symptoms bilaterally. He's yearly having flares with his most recent in the last 2 weeks. Patient was given prednisone by his PCP and reports 90% improvement. The pain is currently localized to his lower back with no radicular symptoms at the time of the evaluation. He had an MRI in 2016 which showed an L4-5 herniation. This case still would be considered acute because it's acute on chronic, and the Startback tool is still appropriate to use for this patient as well. So on the physical exam, there were no red flags, no neurological signs present. He was limited in forward flexion by about 50% by back pain only, and he had noted hypomobility at L3 through 5. No positive special tests were found. Manipulation was indicated as the patient met all the factors for the clinical prediction rule for manipulation. No symptoms below the knee. He had hip internal rotation greater than 35 degrees. The symptom duration was less than 16 days, the acute episode, and his FABQ score was less than 19. And there were no indicators at this point to refer out. So the assessment of this patient, the patient fit into the hypomobility and manipulation category for the treatment-based classification system due to probable facet dysfunction. So the treatment gets a little complicated here. So I'll kind of go through it. I'll try to slow down a little bit because there's kind of a lot to talk about. So treatment number 1, on the evaluation, a grade 5 mobilization was performed with 80% reduction in symptom. So this patient came in with already 90% less pain than he started with. He had manipulation done, brought that 90%, it reduced it by another 80%. So yeah, figure that out. A follow-up phone call was made. So he was manipulated. He was given a home exercise program. He was sent home. A follow-up phone call was made 3 days later, and the patient stated that he had 95% reduction in pain. So he seemed to be doing well. The patient stated that he was following his home exercise program, and he had no other questions about anything. So treatment 2, he returned 6 weeks later with an exacerbation of symptoms. His pain was localized to the lumbar spine. He denied radicular symptoms at that time. However, he was having a lot of trouble bending forward and putting on his shoes. The examination was consistent with his initial evaluation. So it's pretty much the same thing going on, except now he had a 25% reduction in lumbar extension. So he was unable to now extend as well. He was instructed on multifidus activation exercises, and extension-based exercise for home program. Okay, so that was 6 weeks later. Treatment number 3, the patient then returned the following week. So this is 7 weeks after his initial visit, with complaints of left lower extremity radicular symptoms. He had 4 out of 5 strength with great toe extension, which had previously been 5 out of 5. He was otherwise neurologically intact, with 5 out of 5 noted strength throughout the rest of his lower extremity. So he's starting to lose great toe extension. At this point, the patient was referred to Dr. Qureshi for an MRI due to the progressive nature of his symptoms and for consultation for an ESI. All right. So the outcome of this case, due to the progressive nature of the symptoms and the MRI findings of a massive disc herniation, patient was referred to neurosurge. The patient had surgery 11 weeks after the referral from PT was made. This, unfortunately, is still probably better than the norm, but it's not acceptable for this program. So the referral was put in to Dr. Qureshi, and then by the time he saw Dr. Qureshi, had the imaging, it was decided that he would see neurosurge for consultation, actually had the surgery. It was 11 weeks later. So what did we learn from this case? Issues with workflow into pain and spine and neurosurgery, all of those issues that we had were corrected because of this case. There was a lot of conversations that we had, a lot of things that we had to tweak and change, but now the system is working much better. Also, we learned to improve communication, and the referral process was refined. So we talk a lot about talking to the people that you're referring to and how important that is in developing relationships with these physicians. The reason why the first case worked so well, I think, is mostly due to the relationship that Dr. Love and I have. And developing those relationships, it just makes everything faster. Okay, case number 3, Nick Papa Georgio. He had a photo score of 20. Which is very low, of course. His start back tool was a 6 with a psych score of 3, which put him into the moderate risk category. So Nick here, his history is acute onset of left-sided thoracic pain that began while driving. The patient works as a janitor, which requires him to frequently bend, but he's not required to perform any significant lifting. The patient was seen by internal medicine the day before, who prescribed him Robaxin, which gave him minimal relief, if any. In addition, the patient reported experiencing cold and hot flashes, but denied nausea and vomiting. The patient also denied any of the 5 Ds. So the takeaway from his history is that the patient has 10 out of 10 pain, and he's having hot flashes. Okay? So that should sort of start to cue you in, right? So physical examination, he had a temperature of 103. Okay. He also reported that he was having night pain. The patient was found to have postural dysfunction, significant thoracic hypomobility issue. Getting that feedback. Keep going. Go ahead. Okay. Who's the culprit?
No one. It's corrected.
this is what I found, and you know, that's perfectly fine. I mean, some people are not as receptive, that's for sure. But I really haven't found that in our network yet. I haven't found anybody that I've spoken to that hasn't been very receptive of, you know, getting people better. So, can I answer that? Okay, Rick? Yeah.
I know the workflow was great that they had in there.
Yeah.
Got the MRI.
Yeah. She is still being treated by Dr. Love. I actually, before I came in today, actually yesterday, I went through and I reviewed where everybody is with these cases, just in case you got asked. There's actually nothing in it beyond she saw him for an injection. She was doing moderately better, but then it just sort of stopped. And that was, and not to say that she probably doesn't have maybe a follow-up with him at some point, but that was, I think, like 3 weeks ago. So, you know, I think she was told to call if symptoms should worsen or if she wanted to get the second injection, possibly. That's kind of where I left it. Any other questions?
Well, like that's a good example of somebody who should get the injection, and then do they need to come back to therapy or not? You know what I mean? Is there a flow back?
Right. Yeah, absolutely. I mean, that's something I struggle with almost every day. Because like I had a patient yesterday who is a previous patient of mine. I've seen him for several things: neck, his back, his leg, and he came in yesterday and he was like, "I feel great." I was like, "Well, what are you doing here, Bob?" You know, he was like, "Well, my doctor said I should come in after I had my, you know, injection. I feel fine though. It took care of the problem. Do I need to be here?" So I basically did a quick evaluation on him. I you know, looked for strength deficits, looked for flexibility deficits. I was basically looking to recreate symptoms. Nothing. So he's a strong guy. He's at the gym. He's doing his stuff. I was like, "Come back to me if you need me. But, you know, right now you have nothing I can work on." You know, a lot of these times, you know, a patient will have an injection and reduce their symptom, but they continue to have, you know, other issues. Yeah, absolutely. You'll find joint signs or you'll find movement dysfunction or things like that. And you can always address those things. That being said, don't keep patients if you don't need to keep patients. Don't overutilize our services just because, you know, they come back with a script that says, see them for another 2 times a week for 4 weeks. I would never do that. Anything else? Are there questions on here?
Does anybody online have any questions?
Guess not.
All right.
Okay.
Everybody seems like you that they have to refer out. I mean,
About 15%.
About half of mine come through and they are so bad that like no movement, position, nothing. That's anything. And then I either make a call.
Yeah. Right. So our job, we can't get a patient better. If we don't know what to do, we make a referral. You know, and that, doing that, even if you can't get a patient better, you are still doing your job if you're referring them appropriately. And I think that is something that is overlooked in schooling. I think it's overlooked kind of when we come in as therapists. We think that we are just going to treat this patient until we get them better. You know, 3 months later, they're not any better. I don't know what to do. You should have known that, you know, 2 or 3 weeks into it instead of, right, and made an appropriate referral at that time. But about 15% of patients that have come to us, we have referred on, which probably is about right. I'm not quite sure if that number is low or high. I think it's probably a little bit low. I think maybe patients are coming through triage that should be referred out maybe more quickly or would benefit from other services. But we, I think as a profession, tend to just, we're going to kind of grin and bear it and treat this patient, even if they wouldn't necessarily benefit from us seeing them.
And that 15% doesn't include people who triage sent to additional services ahead of time. So
okay.
Only once they come to us
right.
and are just seeing us, we refer out.
Right. So that, let me just repeat that so people can hear it online. That 15% does not include the patients that were sent elsewhere by triage. So if they were sent into the triage line and they were sent on, that 15% does not represent that. What's up?
How many people were you at
For telemed?
Yeah.
You know what? I don't know if we have a number for that. It's
in the 30s.
oh, it's in the 30s.
Not percent.
Oh,
30.
30 patients. Yeah.
I haven't had to do that yet. I'm just wondering if that's something that's commonly be done and just not.
No.
About 3%.
Yeah. No. So Rick's question was, how often is telemed being used through the iPad? The answer to that is about 3% of the time. It's very low, and we have had some issues with telemed, and we've had really good results with telemed using it through the iPad. We're still actually have a meeting, I think next week, with the people through the urgent care. We're trying to take care of some bugs with that. But I've used it probably in all the patients that I've seen. I think I've used it 3 times. 2 times worked perfectly. I mean, it was absolutely everything you could possibly want it to be. And the 3rd time, we were on for like an hour and a half. So it was very disruptive to the patient, myself, and my other patients in the schedule. So, but that's why I'm having this meeting next week. So we're still trying to iron out some of the things like that. Anything else? Okay, I think that's it then.
Thank you very much.
Sure.
Make sure if you are from New Jersey that you do sign out, and if you are if you're physically here, you'll get an email either today or tomorrow from me. And if you're watching this online or watching this recorded, you'll get an email sometime in the next week about how to click and take your quiz. All right, have a great one.